So in this event, experts will talk about the repair procedures and will be enriched by your knowledge. Now I hand over to Dr. Ashish Srivastava, President of AAUP, for his address. Thank you, Dr. Ashish, sir.
Dr. Ashish is there.
Vinay, you carry forward.
Okay. Good evening, everybody. So we welcome you to this AAUP program about PCL injuries. So this initiative has been taken by AAUP about monthly webinar meets, and we will be covering one topic in one day. So it is like PCL this month. Next month, Meerut is doing about multi-ligament injuries, and then Agra, and then Allahabad is doing medial corner injuries. So this is how we are going to proceed. And without wasting too much of time, I would invite Dr. Arun sir to initiate the proceedings and let us discuss.
Thank you, Vinay. Very good evening, friends. And thank you for sparing time and listen to the stalwarts, the panelists over here. So let me introduce the faculty. The speaker number one is Dr. Rajat Kapoor. He is faculty in Sarojini Naidu Medical College, Agra. And he's an ardent arthroscopy surgeon over here, specializing in multi-ligament knee injuries. Dr. Gaurav Rajpal, postgraduate from Safdarjung Hospital and Sports Injury Center, New Delhi. And he too is expert in knee and shoulder arthroscopy. We have a galaxy of panelists. Professor Dr. Vinod Kumar, from Lok Nayak Jai Prakash Hospital and Maulana Azad Medical College, New Delhi, head of the department. And under his belt, there are n number of publications for arthroscopy. Dr. Rajeev Raman, a well-known name in India and around in the field of arthroscopy. We also welcome our Arthroscopy Association Uttar Pradesh President, Dr. Professor Ashish Kumar, and he is heading the Department of Sports Injury at King George Medical University, Lucknow. So welcome all. Welcome Professor Dr. Ashish Kumar. We'd like to have a word from you regarding this event, Professor Ashish.
Very good evening, Arun. And I just congratulate Agra Orthopaedic Association to start this initiative. And I'm audible, I think?
Yeah.
Yes, sir.
Yeah. So Rajat is there. I'm just on my phone, so I just cannot see everybody. That's why. And whatever introduction you have given, I just joined. So I listened partly to this. So what, as far as I have to speak, that it's a good initiative, and Dr. Vinay Pandey, our dynamic secretary, has started this venture along with such kind of people जो हमारे साथ जुड़े हैं, चाहे वो अरुण हो हमारे, चाहे रजत हो. So this is what I have to say कि ये हम लोग monthly event हम लोग ने plan किया है कि this monthly event will take place and will stick to a single topic to which we are going to discuss a little relatively in depth, so that one can get something out of it once he attends the webinar. And one word for the association that we started in 2017 with very few people who are like-minded, and now we are 116. And Dr. Vinay is constantly adding to the numbers. And it's not only the number, but whatever arthroscopy is now being done in UP is that we are at least we are talking about the national level, and everybody is looking at us, maybe this election or maybe whatever it is. So इसी तरह से चीजें बढ़ती चलें हम लोग की, और जहाँ तक स्कोपी हम लोग ने एक एसोसिएशन की शुरुआत की थी जो सोच करके, I think we are progressing towards our aim and things are going well. So I think we should start with the academics now. Enough for the introductory things. Yeah.
Arun?
Yeah.
So I will request Dr. Rajat Kapoor to kindly upload his presentation and start the scientific proceedings.
Thank you, sir. So is my slide is visible?
Yeah.
Thank you, sir. Good evening, everybody. The topic of my presentation is a single stage management of multi-ligamentous knee injury. A multi-ligamentous knee injury is a complex knee problem. It is associated with a subluxation or dislocation of knee joint. It is accompanied by a rupture of two or more major ligament. It constitutes as low as 0.02% of orthopedic injuries. The review of existing published literature reveals the numerous descriptions of various treatment options for patients presenting with more than one ligament injury, but it is difficult to draw any firm conclusion from these studies. Mechanism of injury, the more commonly it is caused due to high velocity trauma, that is road traffic accidents, which is 6.7%. The pattern of injury more common is the ACL plus MCL, that is 70%, and ACL plus LCL is 11.9%. The injury, the multiligamentous knee injury is mostly due to the contact mechanism. That is due to contact or collision that causes the hyperextension with an excessive valgus or a varus force to the knee. The Schenck's classification, as we all know, in the grade 1, the single cruciate plus collateral, ACL plus collateral or PCL plus collateral. In 2, ACL plus PCL with collateral intact. In 3, with LCL and PLC intact, ACL, PCL, and MCL injury. In 3, with lateral collateral ligament injury and with plus PLC and with MCL intact. In grade 4, the ACL, PCL, MCL, PLC, and PCL. In grade 5, fracture dislocation with arterial injury and neurovascular deficit. Types of multiligamentous injury, it can be acute and chronic. In the cases of acute, if there is a chances of neurovascular compromise, then we should go for a ultrasound Doppler and or a CT angio, and after that we reduce the dislocation and counsel the prognosis. And in the case there is no neurovascular compromise, then we reduce the dislocation, fix the fracture, and explain the prognosis accordingly. In case of chronic injury, if it is around 6 weeks old, stable condition in which both cruciates involve PCL plus ACL, then the single stage reconstruction. Single cruciate with collateral, then we go for a reconstruction of the cruciate along with collateral reconstruction. If it is grade 1 or 2, then it is managed conservatively. If both cruciate with collaterals, then it is managed ACL plus PCL, and with the grade 3 injury of the collaterals, we go for reconstruction. Diagnosis, history, and the physical examination, where the test of stability, that is the anterior draw test, Lachman test, posterior draw, reverse Lachman, valgus and varus stress test. On radiological examination, we can go for a stress views of X-ray, that is a valgus or varus stress view, CT scan if there is any bony injury, and MRI. The management controversies are still gray area, that is the conservative versus operative, the timing of surgery, repair versus reconstruction, allograft versus autograft, partial versus total repair, immediate versus delayed mobilization. There is one or several ways, but there is a controversies in the management of multi. Surgical technique which I prefer is the diagnostic arthroscopy performed first, then the graft harvesting, Peroneus longus and semity graft harvested from ipsilateral limb, ACL in case of ACL and PCL reconstruction, tunnel preparation done, and fixation over the femoral side with the bias screw, and on the femoral side with the endobutton loop, and the tibial side with the bias screw. For MCL and NCL reconstruction, minimal invasive technique used. For LCL, fibula based reconstruction done. The weave technique used for a MCL reconstruction, and the Larsen technique for LCL reconstruction. As we all know that the convergence is also a big problem while making the femoral tunnel. In case of ACL and LCL injury, or PCL and LCL, the convergence is a big issue. Gelber et al. Suggested that optimal MCL and POL femoral tunnel both should be proximal and anterior at 30-degree coronal and 30-degree axial angulation to avoid the collision with the PCL tunnels. Tunnel conversion with the ACL is occur up to 75%. LCL tunnel should be made parallel to the distal condylar line and at an axial angle up to 40-degree anteriorly. Now the graft tensioning sequence of graft tensioning in a multi-ligamentous knee injury is also a topic of debate. Starting with a PCL first to restore the central pivot and the tibial step off, followed by ACL in extension to ensure the knee can be fully extended, then posterolateral corner and then posteromedial corner at the last. Moshi and Laprid et al. Suggested that first we should tension the PCL at 90-degree, then fibular collateral ligament in the slight knee flexion and slight valgus, and then PLC structures at 60-degree flexion, and then ACL, and finally the posteromedial corner. The rehabilitation protocol, isometric quadriceps and ankle pumps exercise started from day 1. Knee kept in an immobilization with a knee brace for 6 weeks. Range of motion exercise started from 6th week with a range of motion brace. Open chain and quadriceps and hamstring exercise started at 8 weeks. Patient kept non-weight bearing for 8 weeks. Now coming on to the cases. This is the case 1, 35-year male. Presented with a complaint of pain, swelling, instability, and difficulty to bear weight, left low limb from 3 weeks. On examination, anterior draw test, Lachman and pivot shift test is positive. Valgus stress test is positive on 0 and 30-degree flexion. Slide is not. On radiological, the MRI is suggestive of complete ACL tear with a MCL tear from the femoral attachment. And this is the pre-op clinical test video showing the positive valgus stress test on 0-degree knee and with a 30-degree flexion, showing the medial joint opening. Positive Lachman test. Patient is managed by the arthroscopic ACL reconstruction with a Peroneus longus graft and a semi-T graft for the MCL reconstruction. This is the immediate post-op. At 6 months follow-up. Full knee range of motion with a clinical test, and at 1 year follow-up, patient is doing all sport-related activities. Case 2, 25-year male patient presented with a complaint of pain, instability, difficulty to weight bearing right lower limb from the 5 weeks. Anterior draw test, Lachman and pivot shift test is positive. Valgus test is positive on 0 and 30-degree flexion. McMurray test positive for medial meniscus tear. On MRI report suggestive of complete ACL tear with MCL with medial meniscal tear. Preoperative clinical test video showing the frank positive valgus stress test and anterior draw test. Patient is a 5 weeks old ACL plus MCL plus medial meniscus tear managed by arthroscopic ACL reconstruction with a Peroneus longus graft and with semi-T graft for MCL reconstruction, and for medial meniscus partial medial meniscectomy done. This is 6 months follow-up of this patient. And 1 year follow-up. Third case, a 40-year male patient presented with a complaint of posterior knee pain, instability, and difficulty to weight bearing left lower limb from 6 weeks. On clinical examination, posterior draw, reverse Lachman, and reverse pivot shift test is positive. Varus stress test is positive on 0 and 30-degree flexion. MRI report suggestive of complete tear of PCL with LCL and PLC tear. On examination, SAC sign positive and dial test is positive on 30-degree and 90-degree flexion of knee. The test showing the positive varus stress test on flexion and on extension. Reverse Lachman and posterior draw test is positive. Patient managed by arthroscopic PCL reconstruction with the Peroneus longus graft and for LCL and PLC with a semi-T graft. This is 6 months follow-up of the patient. This is 1 year follow-up. So, what's the advantage of the single stage procedure? The less number of admission to the hospital, unlike in a multi-stage, early mobilization to avoid complications such as arthrofibrosis, less time to achieve full range of motion, early resumption of daily activities and sports, autograft, the less risk of disease transmission, minimize cost of surgery, and less failure rates. Early, in case of reconstruction, early initiation of the rehabilitation, less time to achieve near normal knee function and return to pre-injury activity level, early weight bearing, and excellent results. Take home message: multi-ligamentous knee injury are relatively uncommon injuries, including a large scale prospective clinical and studies and consensus regards its management. Proper evaluation and full diagnosis is a key in a multi-ligamentous knee injury. Failure to treat all injured structure can lead to a change in knee kinematics and poorer outcome and increased risk for graft failure. Single stage early surgical management with proper rehabilitation yields good functional and clinical outcome with early return to work and sports activity. Thank you.
Thank you, Dr. Rajat. Wonderful presentation.
Thank you, sir.
So we will take questions at the end of the session.
Thank you.
So next is Dr. Arun, I think. Dr. Arun? Dr. Arun, can you hear us?
Can you see my slide?
Yeah, we can see your slide. So we'll take questions at the end of the session, correct?
Yeah, correct.
Okay. So we start.
So friends, as we all know that PCL avulsions are quite important in the sense that even a trauma surgeon or a non-arthroscopic surgeon can also treat them accordingly. And here we have taken this topic in order to discuss some facts about this relatively subtle injury. So we'll come directly to the case. So here is a case one, who is a 21-year-old male who Hello. Hello.
You are audible, Dr. Arun, but your slides are not moving. You can do slideshow.
Yeah.
I think, Arun, you need to reshare it.
Now, can you see it?
We can see.
But it is not moving. Just a moment. Yeah.
Yes, moving now.
So there is a history of fall on the knee while running, and he came walking with just subtle limp. He just came a day after the injury and was complaining of discomfort in the backside of the knee and in the calf. He was also complaining because since he lives on the first floor, difficulty in stair climbing and squatting. On clinical examination, there was very minimal swelling. There is small superficial abrasion on the anterior aspect, which is usually a telltale sign for a PCL injury. Posterior drawer on examination was positive, and Godfrey sign was also positive. On X-ray, if you see in a glance, you can miss it out, and you just look for a halo in the intercondylar area on the tibia. If you suspect that there is some cortical breach, you ask your radiologist to have a very perfect lateral view, and there you can see for a cortical abnormality. So true lateral is of great importance. Once you are clinically sure about the injury in the PCL, then you can ask for the MRI, and meanwhile ask the patient to be in a long knee brace or knee immobilizer. An MRI shows you the avulsion from the tibial side, and it can also divulge some facts if there is any concomitant other injuries. And we have seen a plethora of concomitant injuries like patella fracture with PCL avulsion, root avulsion with PCL avulsions, and even proximal tibial fractures in which the PCL avulsions are quite commonly missed. For the sake of discussion, it is the strongest ligament of the knee joint, PCL. It is the main posterior stabilizer. It centralizes the knee and hence acts like a pivot for the knee joint. And the anatomical position of the PCL is vital to restore the pivot of the knee joint. The studies have suggested that chronic PCL insufficiency, howsoever small it is, can lead to early osteoarthritis. So it's like a suicide for the knee joint if the PCL injuries are left untreated. Remember, the PCL, why it is vulnerable to injury? Because it is longer than ACL. It is about 30 to 40 millimeters in length, whereas the ACL is usually 25 to 35 millimeters in length. It is approximately 1.5 times broader than ACL. It has got a large femoral, if you see in the medial condyle, it's a large femoral attachment and a smaller tibial attachment as compared to the femoral attachment, and hence most often than not they are avulsed from the tibial side. So for the sake of management, these sort of injuries have been divided into three parts. Type 1, that is undisplaced PCL avulsion, usually a MRI diagnosis. They are supposed to be treated conservatively. Type 2, you have to be in very close observation. The type 2 means the displacement is less than half a centimeter. And type 3, if it is more than 0.5 centimeter, then that requires surgery. Why? Because chronic, they usually heal because PCL has got a very good blood supply. They are intra-articular structures, but they are extrasynovial, and hence they heal much better as compared to the ACL. But a subtle amount of insufficiency of the PCL can lead to osteoarthritis. So what I did in that case one is that we use two types of approaches to open the backside of the knee joint, and patient is laid on supine position. That is, one is a lazy S incision if the patient is bulkier, and if the patient is lean and thin, as in this chap, we use our own Indian approach, which has been published by Parthasarthi and Gavaskar in 2017. It's a mini open approach, and how to locate the area of incision is you put one K wire at the site of halo, which is vertical, another K wire just perpendicular to it, about few millimeters proximal to the avulsed posterior fragment, and make a transverse nick. As you go to the deep fascia, you will find a short saphenous vein. Do a blunt dissection, retract all the neurovascular structures laterally. You will be most often than not bang on the fracture crater. Clear the crater and reposit the fragment, reduce it, check the reduction under C-arm by fixing a temporary K-wire. I use the shoulder instrument over here to protect the neurovascular bundle, by which we used to use the anchors. If the fragment is big, you can check the rotation of the fragment by means of second K-wire. Check it under C-arm, the appropriate length and the direction of K-wire. Drill it with the help of 3.5 millimeter drill bit. And fix it with the help of 4 mm cannulated cancellous screw. If required, you can, if the fragment is bigger, you can have the second screw. Otherwise, one screw with washer is okay. So this is the pre-op picture and this is the post-op picture. Remember, the screw usually goes medially. So this is just medial to the tibial tubercle, and it is falsely shown short in the C-arm. And if it is beyond the cortex, it will hurt the patient later on if the patient will lean forward or in the kneeling position. So palpate the screw, calculate the exact length, and then only screw the fragment. Hello?
Yeah.
Yeah, I'm again stuck as looks like.
So I think you need to restart again, I think.
I stopped my video. Let me check.
Stop sharing and
Dr. Vinay, meanwhile, if somebody has questions, we can take up those questions also.
So, Rajat, there is a question regarding your talk. Dr. Rajat?
Yes.
Dr. Rajat?
Yes, sir.
So, one of the
I'm
concerns in multi-ligament injuries is a vascular injury.
Yes,
so,
sir.
what's your take on having a check on vascular injury? Either it is by ankle brachial index or
Yes.
you always routinely get CT angio done for these injuries?
Sir, we routinely, I have last week done 2 cases like this, but we palpable the distal pulses and go for a Doppler study.
So you would go to Doppler and ankle brachial index, and
Yeah,
that's it.
yes.
Dr. Prahlad, you have to say something about this?
Yeah, Dr. Vinay. So ankle brachial index in acute scenario is a very good tool, but when it comes for documentation of these injuries, it is a clinical sign which will give you an idea that something is abnormal. So we have to find where the pathology is. So either Doppler will be useful, or you can even go for a CT angio. In case of acute injuries, the CT angio will definitely give you much more information. If it is normal, then we can wait and watch. They say that there is very high chances of intimal injuries wherein the distal pulse will be present, but you may land up in problems at a latest date. So it's always better to document in present scenario, because when we are operating the patient, and if the patient lands up in problem after surgery, then we are in difficult situation.
I think Dr. Arun is again start with the presentation.
Also, the timing of the when the patient presents with a multi-ligament injury. Most of the cases that Rajat has shown, he has shown about 3-4 weeks. So when would you not worry about any vascular injury after the patient presents? Say the patient presents at 2 weeks. So would you actually worry, or this is only when the patient presents acutely in the first week, I suppose?
So
Yes,
first,
sir. Yeah. Shall I take Vinay? Yeah.
Yeah, sure.
Yeah. So even see, most of the multi-ligament injuries, patient might have had an episode of dislocation and he might have reduced himself. So that is very critical because we don't know what happened exactly. So we should take a proper history if that there is any popping sound and like if the patient has reduced himself. So in that case, it is better we do a CT angio or Doppler study, and ankle brachial index will definitely be useful. It will give us some hint if anything is abnormal.
So I think
always,
Dr. Arun is again started.
Yeah, I think so. We
Dr.
can go
Arun?
ahead.
Yeah, sorry for the glitch.
Yeah, that's fine.
Yeah, so it's another different scenario. It's adolescent 15-year-old male ardent football player who sustained a knee injury while playing football. And you can again see a halo in that. And in this perfect lateral view, you see the avulsed fragment in the backside of the knee joint. And since the growth plates have not closed, we have to be very particular about fixing these fragments not to traverse the growth plate. And this has been done with, again, the direction of the screw has to be different and more Shyam check is required while fixing this fragment. So this is a pure epiphyseal fixation in this chap of 15 years. Third, a different scenario, 22-year-old lady, a software engineer, had a dashboard injury while on the road. And the posterior drawer was positive, and X-ray can be passed as normal since it is not a correct lateral view. And you can still, if you are suspicious about the injury, like the calf pain and the symptoms, you can order for further investigation. Fortunately, this patient came to us with the CT scan, and we can make out that there is a displacement of about 0.9 centimeter proximally of the PCL fragment. And since the MRI was not there, we decided to go for arthroscopy in this particular patient. So you can see from the posteromedial view, we have used two different cannulas from the same posteromedial port, that the posterior cruciate ligament has been avulsed with a large fragment in the backside of the knee joint, and which has been cleared with the help of shaver, and at times the radiofrequency is also used in some other cases. The suture bridge technique, as we use it in the ACL, is used here in this young unmarried female who is more keen to get the arthroscopic surgery. The fragment is reduced, and the sutures are taken anteriorly and tied over endo button on the single tunnel. So the choice of fixation depends on the surgeon and at times the patient, whether open or arthroscopic. Open method can miss the intra-articular pathology if the MRI and the radiologist are not of good quality. Usually the MRI will most often than not tell you if there is any significant intra-articular pathology which warrants the arthroscopic procedure. Here I would like to quote our own study from Professor Vinod Kumar Agarwal, Maulana Azad, that posterior cruciate ligament avulsion, a retrospective comparative study, open versus arthroscopic, and they have concluded that both are equally good and both have about 90% success in this study. Another study from Korea in which the similar sort of comparison is done and the results are comparable, but they have found more arthropibrosis in the scopy group vis-a-vis the open group. The reason of this arthropibrosis has not been described in this particular study. Another recent study in 2018 in which they have found that they will prefer open because at times it is difficult to assess a perfect reduction of the fragment in arthroscopy, meaning by that on arthroscopy it looks it has been perfectly reduced, but post-op X-ray shows that there is some fragment which is proud, which is at times we have seen in ACL avulsions also. So the advantages of open method are that it's a familiar approach, it's quite cheap, cost effective, and even a non-arthroscopic surgeon can efficiently attempt it. It is easy to mobilize if there is a large fragment, and at times there is a posterior avulsion of the lateral meniscus or medial meniscus as well, which you can reposit with the second screw. And there is direct vision of the neurovascular bundle, and you can protect it. The disadvantages are that you can miss the intra-articular pathology if you are not supported with a good radiology, that is MRI. Remember, you put a metal screw on the back of the knee joint, which could be difficult to remove if you are performing a TKR later in that particular patient. At times, the patient has got other polytrauma like rib fracture or other injuries in which prone positioning could be difficult. And there could be a big scar in the backside of the knee. And remember, the popliteal fossa is prone to develop a keloid if the incision is bit vertical and more skin handling is done. It can develop a keloid. The advantages of arthroscopic procedure that it is minimally invasive. You can detect the meniscus and chondral lesion at the same time, and there is no implant, solid implant in the backside of the knee joint. Disadvantages are that it is bit technically demanding, especially acute cases. There is a lot of blood even under tourniquet. It requires more time, whereas the open method is like a 30-20 minutes job and attracts more money from the patient because all arthroscopy paraphernalia is used. But remember, despite that technically demanding, once you master the technique, it's not that demanding. It is difficult to discern a perfect reduction at times by arthroscopic method. And once you dissect over there with the shaver or even with the RF, that there could be a fluid extravasation leading to compartment syndrome. The post-op rehab is very simple, that up to 1 to 4 weeks, the knee brace is locked in full extension, toe touch weight bearing is allowed, quadriceps active exercises are promoted. 4 to 6 weeks, 0 to 90 degree flexion under the hinged knee brace and partial weight bearing is allowed. At about 1.5 months, we should achieve about 120 degrees of flexion of the brace and full weight bearing is allowed. In about 2 months, at the time when the bony union is confirmed, you can allow the full range of movement and other strengthening exercises. So, my choice for PCL avulsions, that acute PCL avulsion grade 1 and grade 2, undisplaced conservative, minimally displaced conservative, that is less than 0.5 centimeter. Acute non-comminuted displaced PCL avulsion without any other pathology, then arthroscopic suture bridge fixation. Acute comminuted multiple fragment, even the posterior meniscal root has also got a bony fragment attached with, then I would prefer to go for an open fixation. And children with open growth plates, multi-ligament injury, or any other open injury will go for an open fixation. Thank you very much for your kind
Thank you,
attention.
Dr. Arun. It was a very well elaborated presentation about PCL avulsions, a difficult fracture to negotiate. Now I would invite Dr. Gaurav for his presentation about PCL reconstructions, how to get the tunnels correct. Very important. Dr. Gaurav, are you there?
Yeah.
Start sharing your screen.
I've shared. Is it visible?
No, we can't see your screen.
No, Dr. Arun,
stop sharing your screen.
Yeah, I have done that, sir, but still.
Okay, I'll again share.
So in the meanwhile, I'll take few questions which are there. So
Dr. Arun, I believe, have you stopped sharing?
Yeah.
Because your screen is still visible on my screen, your presentation.
So there's a question, Dr. Arun, there is a question for you. So in the acute scenario, how long would you advise to wait for arthroscopic repair? So to perform arthroscopy, you have all the chances of fluid extravasation leading to compartment syndrome. So how long do you wait for doing an arthroscopy procedure for PCL avulsions, posterior compartment arthroscopy? Dr. Arun?
Is my screen visible, Vinay?
No, your screen is not visible. It's still Arun sir's screen.
No, I suggest Dr. Arun can leave the meeting and rejoin if he has
Arun,
difficulty.
you leave the meeting.
Yeah, and you can rejoin.
Yeah. No, it has come now.
Gaurav sir is. Yeah, Dr. Gaurav, we can see your screen.
Okay. Should I start?
Yeah, start. So we will take all the questions after the end of the session. Okay, Dr. Gaurav, you can start.
Yeah. Good evening, everyone. Thanks, Arthroscopic Association of Uttar Pradesh and Agra Orthopaedic Society for giving me this opportunity. So, my topic will be to cover the PCL reconstruction, specifically the correct tunnel positioning. As you all know, this is a very important factor in the success of any PCL reconstruction surgery. I'll be just touching a few points regarding the anatomy. Arun sir has already discussed some of them. PCL, as we all know, is the strongest and the largest ligament in the body, in the knee joint. And it is intra-articular but extrasynovial, having a great healing potential. And on the femoral attachment, it inserts on the intercondylar notch on the lateral aspect of the medial femoral condyle, has a very wide insertion. And on the tibial side, it inserts on the PCL facet, which is actually a central depression located on the posterior aspect of the upper tibia, about 2 centimeters below the joint line. And the femoral attachment is quite large, almost twice the size of the tibial attachment. It has 2 bundles, the larger one being the anterolateral bundle, which is more vertically oriented. It arises in the roof of the intercondylar notch, and the smaller being the posteromedial bundle, which is sort of inferiorly inserted in the notch. The anterolateral bundle mainly resists the posterior translation of tibia in mid-flexion, and the posteromedial bundle is in tight in extension. Now, these 2 bundles are supported by the meniscofemoral ligaments, namely the anterior and the posterior meniscofemoral ligaments, which sort of aid in stability of the PCL. Now, one should be able to, one should know the actual femoral footprint in order to make proper tunnels. The femoral side, we have 2 bundles distinctly separate on the medial femoral condyle, the larger one being the anterolateral bundle, which inserts in a triangular area formed between the points, that is the trochlear point, which is the highest point of the intercondylar notch, the medial arc point, and the bifurcate ridge. So this triangular area sort of forms the insertion of the anterolateral bundle, and beneath this lies the insertion of the posteromedial bundle. So knowing this anatomy is important when you are reconstructing the PCL, whether you're doing a double bundle or a single bundle PCL reconstruction. Whereas on the tibial side, the footprint is relatively small, about half the size of the femoral attachment, and it lies on the central depressed area on the upper tibia, that is the PCL facet. And the 2 bundles are more or less overlapping here and insert on the posterior tibia. Now, another important radiological landmark when you are reconstructing PCL is the champagne glass drop-off. And when you see the tibia in the mid-sagittal section, the posterior cortex of the tibia, the point where it starts sloping anteriorly, this sort of resembles the shape of a champagne glass drop-off. So this point is known as the CJD, and the whole of the PCL insertion is actually proximal to the superior to the attachment of the CJD in the lateral view. So knowing this surgical anatomy is important, and in order to identify the footprints, you must be able to do a posterior scopy so as to visualize the posterior compartment of the knee joint. Now, after making your standard anterolateral portal, you make a slightly higher anteromedial portal, and then you can use the window between the ACL and the PCL to go behind in the posterior aspect of the knee, or you can also use the recess between the medial femoral condyle and the PCL, where you actually slightly debride the inferior aspect of the PCL, and then you enter the posteromedial compartment of the knee joint. And then you make a posteromedial portal through which you can use your shaver or RF frequency, and you can also view from the posteromedial portal so as to identify the tibial footprint appropriately. So this is where you make the posteromedial portal using first a needle and then a knife. So So after you have made the posteromedial portal, you put your shaver or a radiofrequency probe and you visualize through the high anteromedial portal, and you clean the entire posterior aspect of the upper tibia in the central part at the tibial footprint. Mind you, you have to keep the shaver facing anteriorly so as not to injure the artery posteriorly. You go beneath about 1.5 centimeters, clear the entire PCL facet of the fibrous tissue and the native PCL origin, and then you place your rasp and the PCL tibial jig from the anteromedial portal, and you can shift your scope to to visualize the PCL jig. All the PCL tibial AIMER devices, they have this posteriorly a hook sort of projection about 2 centimeters which rest on the upper surface of the tibia so as to properly guide the tibial pin. Some of the tibial jigs also have provision where you can actually measure the length of the tibial tunnel before drilling, so that you can put a stopper device before drilling your actual tibial tunnel so that you do not penetrate the posterior cortex suddenly and injure the artery. So this is how you place your tibial jig, and on the tibia, posteriorly it rests about 1.5 centimeters below the joint line, and the angle is about 55 to 60 degrees as opposed to the ACL guide where you actually keep it at 45 to 50 degrees because the tunnel is more vertical. In the coronal plane, you keep the jig anteriorly about 4 to 5 centimeters below the joint line and slightly medial to the tibial tuberosity. So what you are drilling is a anteromedial tibial tunnel, which is more central and more vertical as compared to the ACL tibial tunnel that we are quite used to drilling. Some people have advocated drilling an anterolateral tibial tunnel, which actually is shown to reduce the effect of the killer turn at the posterior aperture of the tibial socket. So after you place your guide pin, you have to confirm the position of the guide pin exiting posteriorly. You can do this by either visualizing, putting your scope through the posteromedial portal and visualizing the posterior aspect of the knee joint, or especially when you are doing your initial few surgeries, never shy away from using the image. You should get a true lateral view, and in the true lateral view, you should be able to view this guide pin exiting posteriorly just above the champagne glass drop-off. Another good method to use to confirm the position is using a posteromedial safety incision, where you actually make a 2 to 3 centimeter incision on the medial aspect of the knee, centering the joint line. You go just anterior to the sartorius, and in the deeper plane, you go behind the MCL, between the capsule and the gastroc and the hamstring muscles. You put your finger and you can feel the posterior aspect of the tibia, and then you can feel for the guide pin and the tunnel. This is very important because one of the most common complication of PCL reconstructive surgery is injuring the artery. As you can see, the artery lies very close, about 1.5 centimeters from the posterior aspect of the tibia where the guide pin exits. So in a recent paper from Iran, the authors have given certain few tips in order to minimize the arterial injury and lessen the surgical time when you are drilling the tibial tunnel. And they have advocated that while you are drilling in the lateral view, you should be about 7 millimeters anterior to the champagne glass drop when you are placing the pin. If you are going too far inferior, you are likely to injure the artery, and the visualization of the pin will be more difficult. And if you are more superior, you will be non-anatomical, and you can also injure the posterior meniscal roots and the meniscofemoral ligaments. So the middle picture is the ideal way to put a tibial tunnel. You should not be inferior and you should not be superior. So after you have placed your tibial tunnel guide pin, then you have, before drilling the actual tunnel, you use a hook protector or a curette, which you rest on the posterior aspect of the tibia through the anteromedial portal. And again, you can use the image when you are drilling with the reamer, we should use the same size reamer as the graft. And especially when you are drilling the posterior, the last part of the tibial tunnel, the drilling should be very slow. And preferably it should be manual so that you do not suddenly penetrate the posterior cortex and injure the artery. So although there are many controversies regarding the actual or the correct tibia tunnel, but as of today, this is how ideal tibial tunnel should look like. It should be anteromedial, more vertical. It should be oriented towards the center of the posterior tibia, slightly on the lateral tibial spine, and it should exit on the center of the PCL facet posteriorly. This is the comparison how the ACL, this is the ACL tunnel anteriorly, and this is the PCL tunnel posteriorly. So coming on to the femoral side, again, as already discussed before, the femoral footprint is fairly large. The bundle separation is more distinct on the femoral side. You have a larger anterolateral bundle superiorly and a smaller posteromedial bundle inferiorly. So when you are doing a double bundle, obviously you make 2 sockets in the femur and 1 socket on the tibia. But when you are doing the single bundle PCL reconstruction, the bundle that you are reconstructing is the anterolateral bundle. So what you aim on the femoral side is at the 2 o'clock position in the right knee and the 10 o'clock position on the left knee. And you try to place the femoral jig in the intercondylar notch about 7 to 8 millimeters away from the distal articular surface. If you go more anterior, you are likely to injure the medial the articular surface of the medial femoral condyle. If you go far posterior, you are likely to be non-anatomical. So the dictum for the femoral guide pin is you should be high in the intercondylar notch and shallow. You should not be deep. If you want to err, you can err in the high and low position, but never go deep. So there are 2 methods of drilling the femoral tunnel. After you have placed your guide pin, you can either go inside out, that is, you are drilling from the anteromedial portal and exiting on the outside of the medial side of the knee, or you can use a PCL femoral jig and you can do outside in drilling, where you are drilling your guide pin from outside the medial aspect of the knee and you are exiting on the intra-articular in the intercondylar notch. Then once you have placed your guide pin by outside in technique, which is the preferred technique, there are 2 methods of drilling the socket. You can either drill the socket in an antegrade fashion, where you can drill from outside to inside, or you can go retrograde, where you actually use a flip cutter and you drill your socket from inside to outside. Now, this actually, by doing retrograde outside in drilling, you can also use suspensory fixation devices like an endo button, which you cannot use by antegrade drilling. So this is the outside picture of how you place your PCL femoral jig. The point where you place your jig outside is roughly the midpoint between the medial epicondyle and the medial surface of the superior patella. And you orient your jig almost parallel to the transapicondylar axis. So when you're doing a double bundle PCL, in a single bundle PCL, you are mainly reconstructing the anterolateral bundle and you drill a socket which is more high in the intercondylar notch. Whereas in a double bundle PCL, obviously you drill 2 sockets, one for the AL bundle and the other for the PM bundle, and there should be about 2 to 3 millimeters of gap, a bony bridge between the 2 bundles. Another important factor for failure of the PCL surgery is killer turn. So when you are making tunnels, you have to be careful that you reduce the effect of the killer turn. The killer turn is actually the acute sharp angle that is formed by the graft at the posterior aperture of the tibial tunnel. And it is important that you drill the tunnel on the tibial side more vertical. It should not be horizontal because it will increase the acute angle. And on the femoral side, it has been shown that outside in femoral drilling makes a gentler curve on the femoral side, whereas the inside out femoral tunnel increases the curve of the graft on the femoral side. Also, one should rasp the aperture of the socket in the joint On the tibial side, you have to rasp the anterior surface of the posterior aperture, and on the femoral side, the posterior surface of the femoral socket should be rasped so as to reduce the killer turn. Again, as I told initially, that some have advocated anterolateral tibial tunnel to reduce the killer turn, and if you want to totally avoid the killer turn, you can use a PCL inlay technique. So once you have made proper tunnels, then it is a very easy job. You pass your sutures and you pass your graft from the tibia to the femur, caudal to cranial. Although some surgeons have now advocated passing the graft from the femur to the tibia. Then you can use your appropriate fixation devices, either a bio screw or a suspensory fixation like an endobio. So my take-home message will be, one should, for a successful PCL reconstruction and drilling good tunnels, one should know the anatomy, identify the footprints clearly. One should always try and do posterior scopy, because visualizing the posterior side of the knee, the tibial footprint, and avoiding injury to the artery makes the job very easier with the posterior scopy. Do not shy away from using the image, especially during the initial few surgeries or even the posteromedial incision. As opposed to ACL, where we actually drill a size, the tunnel size is maybe a size less than the graft diameter. In PCL, always drill same size tunnel as the graft diameter. Try to avoid, obviously, the injury to the artery if you are careful in the posterior side. Injury to the cartilage of the medial femoral condyle or the menisci posterior roots. Always smoothen the edges of the tunnel. This will increase the longevity of the graft. And try to minimize as much as removal of the native tissue at the footprint so as to preserve the stump, because this aids in healing and adds to stability. Thank you for your attention.
Thank you, Dr. Gaurav. It's very elaborative kind of presentation. So now we move to the next presentation by Dr. Rajeev Raman, a wonderful technique of harvest of quadriceps. So Dr. Rajeev, are you there?
Yeah, I'm here. So thank you, Agra Orthopaedic Association and AAUP for invitation. And as we are discussing about the PCL, what two important things for graft choice in PCL is that you need a longer graft and you need a thicker graft. These are the two important things we want in PCL. Unlike ACL, where you can compromise with 7.5 or 8 millimeter, in PCL, your graft should be at least 9.5 millimeter in diameter, and length should be at least minimum 11 centimeter. So I call it a forgotten graft because earlier we were using the central slip of the quadriceps tendon, and the two important factor was that most of the patient has some amount of quadriceps weakness or extension lag in due follow-up. So let's discuss the anatomy of the quadriceps. If you see the sagittal section, you can see normally the thickness of the quadriceps tendon varies from 8 to 14 millimeter in the sagittal section. So most of this weakness and extension leg of the quadriceps tendon was because we were harvesting the full thickness of the quadriceps, and there was delay in rehabilitation. There was more anterior thigh pain, and some of the patient used to present with some amount of 5 or 10 degree of extension lag. So what we started doing for last 2 or 3 years is we are harvesting the superficial quadriceps. So the superficial part of the quadriceps, leaving the deep part, the part which is close to the rectus, intact, so that you are harvesting only the partial thickness of the quadriceps tendon. So this is a small video demonstration of superficial quadriceps harvesting. You can see this is the lateral side and this is your medial side. You are marking this is the upper pole of the patella. Normally you make 1 to 2 centimeter of this incision toward the lateral part. You can see if this is the thickness of the patella is 5, so you make your incision towards the lateral part, because quadriceps is more tendinous on the lateral side and you have more muscular structure on the medial side. Normally you can make this take the superficial quadriceps graft with a 1 or 2 centimeter incision only. Make a small vertical incision 2 to 2.5 centimeter. Make a sharp dissection over the patellar retinaculum. You can see here with a 11 number blade, and now try to dissect your particular retinaculum. And you can see the thin shining quadriceps tendon here. And normally it's the right angle artery, which is a good guide how much of the depth you should go inside. You can see normally it varies from 8 to 9 millimeter, and that will guide you about the length of your breadth of your quadriceps tendon. So you can take 6 to 7 millimeter of the breadth. You can see here, you can measure, and the side angle artery forceps is a good measurement. Otherwise, you can use your Smith and Nephew measuring scale also for that. Again, for depth, this is a very good technique. Normally, the right angle artery forceps has a, you can see here, it's around 8 to 9 millimeter. So try to take superficial part of the quadriceps, that is 6 to 7 millimeter here. And you can see here, that is the thickness of the quadriceps you are taking around. So two things is important. First is the graft, you are taking a superficial part. Now try to make a subperiosteal resection over the superior aspect of the patella. You can see here, and try to elevate your whole of the quadriceps tendon. You can see this is subperiosteal exercise. Sometimes you can take a bone plug also. I don't prefer taking a bone plug. I only resect it subperiosteally. You can see, you can resect it subperiosteally. And now you have a quadriceps stump, superficial quadriceps stump, I can say. Make your VP stitch there. Now take 4 or 5 VP stitch, so that, because quadriceps is a very strong tendon. I think the maximum force you utilize in harvesting any tendon is the quadriceps tendon, and try dissecting it. This is very meticulous process. So try to dissect so that you are not going in depth and you are not violating the suprapatellar pouch. So try to take the superficial part of the quadriceps. You can see here, this is superficial of the part of the quadriceps, and you can see the deep part is intact. The deep part of the quadriceps is still intact. And this is the part of the quadriceps we are harvesting. You can increase the breadth of this tendon while you are going upward. You can see here, and this is the deep part of the quadriceps which is intact. And now, with a closed tendon stripper, which we use for cemetery graft, introduce it inside. And this is a very small technique. Start pushing it in 90 degrees of flexion. Once you are inside, gradually ask your assistant to extend the knee, because that will make your quadriceps relax. And that is the time you can see you can harvest the whole of the superficial quadriceps. You can see a long length of quadriceps, thick quadriceps tendon is out with a small incision. Here you can see. So normally you get around 28 to 32 centimeter of the graft with this small incision. And 3 important tips is important. You can see here the length is around 32 centimeter. So this is very good for making your PCL graft, because PCL normally you need a longer graft and you need a thicker graft. So I think now it is after, and now you can see here, this is this deep part of, you can see whole of the deep part of the quadriceps is intact. You have not violated the suprapatellar pouch. Now try to make give 2 or 3 stitches over the superior to repair the patellar retinoculum, and you can just stitch the wound with just, you can see this is the size of the wound around 2.5 centimeter, and you can see a thick 9.5 millimeter graft is there, and you can see with around 10 to 11 centimeter of length. So why it is important and superficial quadriceps, and why we are now thinking about more of harvesting the superficial quadriceps, because it has lessened the weakness of the quadriceps. Most of the patient, as in the hamstring graft harvesting, you have patient will have a posteromedial thigh pain. The quadriceps graft harvesting, sometimes you have a anterior thigh pain. Most of these patients have anterior thigh pain because you are putting your tendon stripper anteriorly. So if you take a full thickness graft, the chances of having the anterior thigh pain is more compared when you are taking a superficial quadriceps graft. Yes, the rehab is very early because you are not harvesting the full thickness of the quadriceps graft. You can put them on rehabilitation on the next day, as we do it is with the cemetery graft or a peroneal graft. And definitely most of these patients, we have till now 21 patients follow-up has no extension leg because we are not harvesting the full thickness of the quadriceps graft. Thank you so much.
Thank you, Rajeev sir. A wonderful presentation, and it's a very famous technique that you have shown already on a lot of platforms. We have seen this. Now we come to the last presentation for the day. Dr. Arun is going to talk about Peroneus longus harvest. Dr. Arun?
Yeah.
So you can start the screen sharing.
Can you see that?
Yeah. Go ahead.
So after a wonderful demonstration by Dr. Rajeev, so why we are searching for the graft? Because we are seeing more multi-ligament injury, and at times in our patients, especially in females, the graft diameter is inadequate. And at times, since the bulk of the ligament reconstructions is increasing. So as far as the number of orthopedic arthroscopic surgeons are also increasing, there is more revision scenarios as well. So we require a good, robust alternate grafts as well. So here is the video, small video of the Peroneus
technique of Peroneus tendon graft required for various knee reconstruction surgery. A point about 2 centimeter proximal and about 1 centimeter behind the lateral malleolus is identified, and about 1.5 longitudinal incision is made on the prominence.
Can you hear the video, audio as well?
We can hear the audio and the video as well.
Yeah.
Cut by sharp knife in the same plane. A tissue scissor and cat's paw retractor is used to dissect the peritoneum from the Peroneus longus tendon. A 90-degree hemostat is used to hook out and deliver the Peroneus longus tendon. Remember, the longus tendon is more lateral and posterior to the brevis tendon and is devoid of any muscle attachment in this part of the leg. Try to free it off any soft tissue. Put a long forceps and ask your assistant to pull it and invert the foot so that you can get the maximum length, and cut it from the distal part by sliding the knife inside the furrow of the forceps. Hold the tendon by a Cocker or a Alice forceps. Tendon is usually quite slippery over here. And weave the tendon with the help of number 2 fiber wire or Ethibond. Technique of Peroneus.
Sorry.
I think you have to unshare the screen and then again share.
Some problem from the laptop side problem.
Yeah. So you can unshare and share again. So in between, I can take some questions because we are running a little late. So there's a question regarding PCL avulsion. So is there any role of CT scan as an investigation in PCL avulsions? Dr. Rajeev?
I think sometimes most of these avulsions are associated with some amount of proximal tibial plateau fractures also. So you can have a And two things are important. Once you do CT, you can assess your size of the fragment. That will determine you whether you are planning for an open or arthroscopic procedure. Second thing is that sometimes you have a comminuted fragment also there, when it's very difficult to fix it openly. So in those cases, it will help in your planning also, because smaller fragment, comminuted fragment, most of the time we prefer fixing them arthroscopically. Large, very large fragment, normally we try to fix it through the mini open technique.
Yeah. Vinod sir is there? Dr. Vinod? Yeah, there, sir.
Hi. Good evening to all.
Good evening, sir.
Yes.
Good evening, sir.
Yes.
So, how long do you wait before doing an arthroscopy in a acute case of PCL avulsion? Suppose if you are fixing it arthroscopically. So, is there a time duration because you are worried about compartment syndrome and fluid extravasation?
Yeah, actually, because I am in a government setup, so generally the problems are of that patient comes late rather than early. So, but yes, theoretically, it's a problem that if you go for an emergency type of situation, so probably you should avoid at least 3 days, 3 to 5 days, according to me, just to rule out certain other major problems sometime which may be there. And then you can go ahead and do. I don't think under expert hands it take more time, and extravasation really is a problem. And second important thing is that to avoid this extravasation, you can use some sort of compression bandage in the lower part of the limb till mid of the calf. So I don't think there is too much worry until unless you are venturing as a first case or you are in a learning mode, then probably it may be a worry, otherwise not.
Yeah. And the vision is an issue, but pump should never be used in these cases, acute cases.
Yeah, that is again very important. And most of the time you use the cannula, so fluid keeps on extravasating. So it's never under high pressure until you are really struggling for a long time.
Oh, Dr. Arun, can we play again?
Yeah.
Sure, start. Or it stopped again, I think.
Yeah.
So another question is, does the size of the fragment in PCL avulsions determine the type of fixation? I think Dr. Rajeev answered this.
Yes.
For comminuted fragments and small fragment, use suture-based technique, and for bigger fragments, one can use screws. Dr. Rajeev, what is a preferred approach for the fixation of this fragment open technique? It's a direct posterior or this Burke's approach, which has been promoted of late?
Yeah, I think direct. Whenever I am doing it open, I do it at a direct posterior approach because I'm used with that approach. But yes, Burke approach also, some of the surgeon prefers Burke approach also. So I think direct posterior approach is the best approach for PCL avulsion.
Vinod sir, any take on this?
I agree. You see, approach both are right, but I generally go with the Burke's approach between semi-membranosus and medial head of gastrocnemius, because that gives me a lot of, you can say, confidence in terms of protection of central neurovascular structures. And I think initially you should go with that, because in direct approach, probably the care of central neurovascular structure require more meticulous identification and separation. Otherwise, you may stretch them and all that. But only thing is that by direct approach, probably you feel comfortable in fixation and all that and visualization. In Burke's approach, there is little bit constraints to actually make the bed free and reduce it and all that. But I think by little bit practice, you can do that very safely. It's not a problem.
There's a question.
Vinay?
Yeah.
We have a paper, Vinay, published in JAJS about the PCL avulsion injuries. So we had 54 cases, which was published in 2018. So we follow the modified Burke-Schafer's approach. So it is a very simple approach. You can finish the procedure in 45 minutes to 1 hour. So time is not a matter, but just I'm telling. And also, as Sir Vinod sir pointed out, the retraction is little difficult. So there are two simple techniques. What we follow is we keep a bolster below the thigh so that the tibial sacs get corrected. once you keep a bolster below the thigh in the prone position, right? So the tibial sacs gets corrected automatically. And the incision, we try to take just a few millimeters above the popliteal crease, so that you get a better angle to put your guide wire into the tibia. If you take it at the popliteal crease or below the popliteal crease, you will struggle in putting the guide wire. So these are just two modifications which we have done. And I think so it's a very simple procedure. You can finish in time. And also you can protect the neurovascular structure.
Thank you, Doctor. Dr. Arun, we can go ahead.
Yeah. So, sorry for the glitch. You put few whip stitches. You put few whip stitches. And dilate the peritoneum. Can you see the video moving, Vinay?
Yeah. Video is moving.
And one need to use a larger diameter tendon stripper.
It has stopped again, I think.
This is 7 mm tendon stripper. In order to negotiate the thickness of the Peroneus longus tendon. And ask your assistant to mark the fibular head in the proximal part of the leg. Once you start sliding the tendon stripper towards the proximal part of tendon. It's not moving smoothly. Huh? So this is the direction. And you can see the tendon stripper is going. Nudge and negotiate about 4 centimeters before the fibular head in order to avoid any injury to the lateral popliteal nerve. And you can get a good tendon length at your hand. So, can you see the presentation?
Yeah, video has stopped. Video has stopped. No presentation.
Okay.
So, Dr. Gaurav, are you there?
So,
Dr. Gaurav?
Yeah.
So let me just conclude, Vinay.
Yeah, sure. Yeah, sure.
So the presentation is not getting uploaded. So it's a technique which is a bit new as compared to other tendons available to arthroscopic surgeon. And there is a latest paper by late Freddy Fu, which has been published in Knee Sports Injury and Traumatology, which says that the results of hamstring tendon vis-a-vis Peroneus longus tendon, the re-rupture rates of Peroneus longus tendons are quite less, almost half that of a hamstring tendon. And it can be considered when the tendon diameter, while you are harvesting the hamstring ones, are below the normal, that is about 7.5 millimeter. And this technique should be up the sleeve of all arthroscopic surgeons while you are doing any multi-ligament or revision surgeries in the knee joint. Thank you. And thank you very much for bearing me for this technical glitch.
Thank you, Dr. Arun. I think there are 2-3 questions left, which are in the chat box. One is about Dr. Gaurav. Are you there?
Yeah.
So do you depend on these bony landmarks that you described in your presentation for making femoral tunnel, or it's more or less like eyeballing and that is how you decide?
Again, what I basically, when you reach the femoral side, you are mostly at the end of the tunicate sign, so you are in a bit of a hurry. So what I mainly see is that you are about 7 to 8 millimeters from the articular surface. you are not too far anterior or too far posterior, and you are slightly higher on the notch. That's it. Because I'm mostly a single bundle PCL reconstruction surgeon. I never do double bundle. So on the femoral side, it's fairly easy. And as I said, on the outside, you keep it on the midpoint between the superomedial patella and the medial epicondyle, and keep the jig sort of parallel to the transepicondylar axis, or slightly about 10 to 15 degrees at an angle to it.
Vinod sir, any tips about this femoral tunnel placement in PCL reconstructions?
I think in my practice, generally, what I have realized that PCL most of the time on femur side, the remnants are always there. So I actually most of the time use that footprint itself as a guide that you should take, and like already in the lecture have been highlighted, most of the time if you are doing single bundle, then you should take the anterolateral center or little bit down, and if you are doing double bundle, then you can demarcate the centers of both bundle. And most of the time on femur side, PCL footprints are almost always visible. Otherwise, you can have these guidelines of markers and your jigs which are calibrated, you can make out either by outside in or inside out. So hardly any problem most of the time.
So Vinod sir, do you advocate the tibial tunnel if you are passing the graft from tibia to femur, making about half a millimeter more than the graft diameter to smoothly pass on your graft, or you make the same size tunnel?
Yeah, it's better. It's always better to have 0.5 mm more. For surgeons, it makes life very easy. There is no harm to do that.
And do you recommend, I have seen in one of your presentations as well, that a dual fixation on the tibial side for all PCL reconstruction, because gravity is a big anti-factor in PCL reconstructions?
Yeah, actually that depends on your technique. Like in PCL, if you calculate the length of tibial tunnels and all that, the length required of graft becomes very, very long. And that compromises the diameter. So what I do generally to improvise the diameter, I make the graft length little bit compromise. So what happens, this graft does not come till the aperture. So what I use generally in that situation, I use a interference screw as an sort of near aperture fixation, go inside and fix that in the tunnel, inside the tunnel, and those sort of bonds which remains outside, secondarily I put on some post of suture discs, etc. But if you have these newer grafts in your practice, like Dr. Rajeev has demonstrated, or with this Peroneus longus now, and you have adequate length coming till the aperture, then you can probably have a good long interference screw and you may avoid that. So that depends on situation, and that hardly adds any complication if you add further, hardly with 500 rupees more cost. So that was actually in that reference.
Rajeev sir, always better to use the double fixation on the tibial side.
Yeah, there is no harm in that at all.
Sir,
Rajeev
double fixation. Sir,
yeah, Sunny, please.
Sir, double fixation done by suture disc or either screw?
Post. Tibial post mostly we use.
Post or disc, both you should do along with interference screw.
Along with the interference, in the same direction. On the line of force, tendon is a line of force, the tendon tension is the same direction, same angle. If we put a screw, the tensioning tendon is changed, in the direction has changed.
I couldn't get it. What exactly is the problem?
Exactly, sir. I want to know that the screw, double fixation for a screw is better, or either suture disc is better.
You are using both. You are using a screw as well as a suture disc.
Yeah. Suture disc, I think I prefer the suture disc, not a screw.
No, you see, double fixation is basically once you have already fixed by interference screw, that is already there, but still you feel that fixation is not good. So you supplement by second fixation on the aperture, either by tying those free end on the suture disc or by putting some screw as a post.
Actually, sir, in the screw, I some few cases I have seen. So the tensioning force is direction change in the screw by the thread to interference screws. The tensioning is around 45 degree on the vertical axis of the just if you see the vertical axis of the tibia and axis of the interference screw is around 45 degree. But if the thread is pulling the force, so by the screw in the vertical axis of the tibia, so that it loosen the interference screw. What I mean to say, it loosens the interference screw, sir.
That probably may happen if your screw size and diameter mismatch is there. Otherwise, it should not happen. If you will use two small size screw, then you may have this divergence phenomena and what you are saying, some looseness of tension and all. If you are doing a adequate fixation, then I think both these things should not happen.
Okay, so we take the last question for the session. There is a question by Dr. Dhawan. Any specific indication for double bundle PCL reconstruction, Dr. Rajeev sir? Any specific indication for you there? You're going to do only a double bundle PCL reconstruction?
Usually, I do a single bundle PCL reconstruction only. So till now, I have not preferred doing a double bundle, either ACL or a PCL. So I think it should be a thick graft. 10 to 11 millimeter is a good graft. I think that single bundle is good enough for PCL reconstruction.
Dr. Rajesh sir, one question. What is your first preference for your PCL grafts? Is it the Peroneus or the CPC?
Always Peroneus. Most of the time I use a Peroneus with a CMT because then you have a good thicker graft and a longer graft. And sometimes, suppose the patient with multi-ligament injury, yes, I prefer taking quadriceps also.
So Peroneus with a hamstring.
With the hamstring. Then you have a thick graft and length is because you need 11 to 12 centimeter of length. It's not possible with the Peroneus also.
And what size screw you are using on the tibial side if you have 11 or 12 millimeter graft?
So suppose if 10 to 11, I think it's a 9.5 usually. So most of the time it's not 11, it's 9.5 sometimes. So it's very rarely it's 11. Yeah.
So use a 10 or 11 bioscrew.
Yeah, 10 or 11. And I always I tell to say regarding the disc and the post, if your graft is inside the tunnel, always try to put a disc there as a supplementary fixation. If your graft is outside the tunnel, try to put a post. I think that is the standard practice I prefer in putting a supplementary fixation for the PCL.
Any of us doing inside out drilling? Vinay, Dr. Vinod, sir?
Yeah, actually, I'm doing it very regularly now. And my rather preferential technique for PCL remains all inside technique now, because that save me a lot of problems of graft length and all. And now in my practice, by doing all inside, I manage with 75 to 80 mm length, and which comes even by single Peroneus very well.
So you triple the Peroneus.
Yeah, because you can make it quadruplet and it becomes almost 10 or even 10 plus sometime. So I think for PCL, it is a good technique. We should start to practice that.
I think Dr. Rohit had asked one question twice. What is the sequence of fixation of graft in multi-ligament injury? Dr. Rajat, you have to answer this, and this is the last question.
Yeah, the sequence which we usually follows is the PCL tensioning first. To prevent the sagging of the tibia, followed by ACL, and then posterior lateral corner, and then posterior medial corner to be fixed to be last.
Rajeev sir, you have some different take about this? PCL, ACL, lateral and medial. That is That is
So I think third and fourth point, yes, you may vary, but always try to centralize your knee first, because your central pivoting axis is your PCL. So once you have centralized your knee, you can build your collaterals and you can build your ACL over that. So PCL, ACL, MCL, and LCL, most of the time, if you are reconstructing your PCL, MCL, and LCL, don't go for ACL reconstruction. The knee is going to be stiff enough to give any type of instability. So I usually...
Your take? Vinod sir, your take on this?
Yeah, I think I agree with that. Central sort of stabilizer has to be taken first. But there is one thing which you should keep in mind, that if you do this thing, sometime what happens, you may fix the knee in some mal rotations or varus or valgus. And because you make them tight, so you create a very stiff thing without even taking up the corners. And then you cannot do your proper isometric corner repair. So actually you have to take a balance call, and sometime in a very grossly unstable knee, I have to change my sequence. Like I am doing KD4 or something like that. Then I make the tunnels past these grafts, central grafts. And in that case, I align the knee and take these corners fixation and followed by these tibial, PCL, ACL and like that. So, but if it is simple, you can say ACL, MCL or PCL, PLC, then you can go with PCL first, stabilize, and then you can do the corner repair. But you have to be taking this care. I have seen that if you have done that and you have fixed the knee in varus or valgus, and then you do corner repairs in a wrong position. So that precaution you should take, especially in KD3, KD4, once the situation is grossly problematic, then in those situations, corners may take over centralize just in sequence. So you have to individualize in particular situation.
Vinay, one last question, if you permit.
Yeah, sure.
Yeah. Regarding combined ACL and MCL injuries, where the MCL is torn from the femoral side. So, Dr. Rajeev and Dr. Vinod, sir, so what is your preference? Whether you would reconstruct both or you would wait for the MCL to heal and do the ACL later? On the femoral side, MCL from the femoral side, grade 3.
You see, if it is a fresh tear, then repair on femoral side MCL is fantastic results. Very simple and very good results. So if it is an early situation like within 3 weeks, and I see that MCL has just come out from femur side, I always repair it by putting an anchor and take it and strengthen, and then it gives very good. Even in late cases also, sometime still I find that I put an anchor repair and supplement with reconstruction, because the results of MCL reconstructions are not as great actually. So I always take advantage of repairable tissue if it is available, and on femur side it is almost always there. So I think you can take that advantage of repairability on femur side, and it hardly takes 5 minutes. And you just put an anchor and take it, and your meniscofemoral opening which was there get reduced immediately.
So you don't augment the primary repairs? You do not augment the primary repairs in acute situations?
No, I don't. If it is a primary and it is a plain femoral side injury of MCL, I do ACL and just repair.
Dr. there is a wonderful technique by Lobenhofer regarding this femoral avulsion of MCL. Very well described by Lobenhofer. I think I'll share the article with you. So I think we can wind up the session. We are already late. I would invite Dr. Sanjay to have final words about Agra Orthopaedic President, sir. Kindly have few words about the session.
Very good evening to all respected delegates who have been attending this arthroscopic webinar. The webinar was jointly organized by Arthroscopic Association of UP and Agra Orthopaedic Society. This is a great initiative taken by Arthroscopic Association of UP. Being our first attempt from Agra Orthopaedic Society, it might have had few shortcomings like video uploading and everything, which I hope you people will understand and ignore and forgive us. On behalf of Agra Orthopaedic Society, I thank you all for attending this wonderful academic feast, which had been prepared by hardworking, worthy speakers. Thanking you once again and hoping to meet you all more frequently in future. Thank you very much. Good night.
Okay,
thank you everyone.
Thank you everyone.
Thank you,
Arun and all the team. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, Steven. Yeah.
Thank you.
Thank you, OrthoTV.
Right. Thank you so much for your all guest panels and speaker panel, even Dr. Ashish sir, Dr. Vinay sir. I am Satendra Tiwari as a regional manager, Cross and Lab Division of So in future also, we'll keep on organizing such events, sir. Thank you so much for giving your precious time. And thank you once again. Yeah.
Thank you.
Thank you once again.
Thank you, sir.
Okay, bye-bye. Thank you, sir.
Bye, sir.
Bye.
Thank you, sir.
Recording stopped.
सर अब AOS की मीटिंग कब करा रहे हैं?
तो बता दीजिए जब कराने को।